Of you. Today is 21st of November. Today we are going to discuss about the three important poisons and their management. And last class we had discussed about the general principles of acute poisoning. And today we will be dealing with the specific poisoning, individual poisonings today. So today is 21st November. Today is Tuesday. Today we are going to discuss three important poisoning, that is their management part. Number one is paracetamol. Paracetamol toxicity. Or overdose. Number two is aluminium phosphide poisoning. And number three is organophosphate poisoning. Why I have selected these three poisoning? Because paracetamol is a very commonly used drug and it is easily available to the people, and that's why it is not difficult to find cases of paracetamol toxicity. And aluminum phosphide, it is also called cell phos poisoning. Cell phos poisoning. It is used as grain preservative, and that's why it is easily available with people, especially from rural background. And this poisoning is very frequent in our setup, in our Anugrah Medical College, Gaya. And organophosphate, again it is a insecticide, and it is particularly used by agricultural workers, and that's why its exposure is also very common. And one special thing about organophosphate poisoning, it does not always need ingestion. Even the inhalation or surface contact leads to poisoning. Therefore, the treating physicians who suspects the organophosphate poisoning, first of all, he should wear the protective covers. Like if it is possible to take the protective gown, and at least gloves should be there, mask should be there, so that patient does not, doctor, treating physician or the staffs also should take protective clothing, so that they don't get exposed to organophosphate poisoning, because even absorption or surface contact leads to toxicity of organophosphate poisoning. So let us start with the paracetamol toxicity or paracetamol overdose today. Now we are to discuss about the management part. So in case of paracetamol toxicity, first thing to do is we have to get the paracetamol concentration. So number one point is paracetamol concentration. first thing to do is to get the paracetamol concentration. But when? This is an important question. For at least 4 hours after the ingestion of paracetamol, one should get the concentration of paracetamol. And if the 4-hour period has already been passed, then it is as soon as possible. You should take the concentration of paracetamol. 4-hour concentration, at least 4 hours should be elapsed to get the concentration of paracetamol. So, paracetamol concentration should be taken at least 4 hours after ingestion of paracetamol. And number 2, liver function test should be done, because paracetamol is a hepatotoxic drug. If taken in overdose, it leads to hepatotoxicity. Therefore, LFT is the second thing to be done in the management of paracetamol toxicity. And number 3 is updated Matthew nomogram. I will be telling you about this updated Matthew nomogram. With the help of this nomogram, we interpret the concentration of paracetamol if the patient presents in the first 24 hours of paracetamol ingestion. And for its interpretation, one more condition is that the AST should be normal. For correct interpretation of Matthew nomogram, the AST should be normal. What is the nomogram? We measure the time since ingestion. Time since ingestion and level of paracetamol concentration. Time since ingestion and level of paracetamol concentration. It is written at 4 hourly, 8 hourly, 12 hourly, 16 hourly, 20 hourly, and we get the concentration of paracetamol. This is called time since ingestion of paracetamol and concentration of paracetamol. This relationship is called updated Matthew nomogram. So, if it is 150, 75, less than 175, less than 37.5, less than 18.25, 18.75 and 9.375. If after 4 hours of ingestion of paracetamol, the concentration of paracetamol is less than this much, this is in micromole. If after 4 hours of ingestion of paracetamol, concentration of paracetamol is less than 150, then hepatotoxicity is unlikely. If after 4 hours of ingestion of paracetamol, concentration of paracetamol is less than 75 micromole per liter, hepatotoxicity is unlikely. If after 12 hours of paracetamol ingestion, paracetamol concentration is less than 37.5, hepatotoxicity is unlikely. If after 16 hours of ingestion of paracetamol, the concentration of paracetamol is less than 18.75, hepatotoxicity is unlikely. If after 20 hours of ingestion, paracetamol concentration is less than 9.375, then the hepatotoxicity is unlikely. So the real value, real significance of this updated Matthew nomogram is it rules out hepatotoxicity or whether the hepatotoxicity is present. If after 4 hours of ingestion the concentration of paracetamol is more than 150 microgram per ml, it means patient can develop hepatotoxicity, and accordingly we will take preventive measures. Okay, so this is about updated rheumatic Matthew nomogram, and now this is the investigation part, and the management part is antidote. Number 4 is antidote. For possible or probable paracetamol toxicity, antidote is N-acetylcysteine, as I have already taught you in the previous class. N-acetylcysteine is the antidote for paracetamol toxicity, and this is given in two forms. We can give either oral dose or IV dose. How the oral dose is given? The loading dose for oral is 140 milligram per kg body weight. This is the loading dose, 140 milligram per kg body weight, and thereafter 70 milligram per kg body weight for 17 doses, means total 17 doses, means in totality we have to give 18 doses. First will be the loading dose. Oral dose will be of N-acetylcysteine will be 140 milligram per kg body weight, and thereafter we will give 70 milligram per kg body weight for 17 doses at 4 hourly interval. This 70 milligram per kg body weight for 17 doses will be given 4 hourly for 17 doses. So total there will be 18 doses in case of oral dosing of N-acetylcysteine. We are talking about paracetamol toxicity, and we have reached to the level of antidote. The antidote is N-acetylcysteine, and we can give it in oral form. Oral dose is 140 milligram per kg. This is the loading dose, and thereafter 70 milligram per kg body weight for 17 doses at 4 hourly interval. So this is oral dose. Now the IV, for IV administration of N-acetylcysteine, we use the nomogram, as I have already told you in updated rheumatic Matthew nomogram, in which when to start N-acetylcysteine, then when at 4 hours the concentration of paracetamol time since ingestion and concentration of paracetamol. When concentration of paracetamol at which N-acetylcysteine will be started. N-acetylcysteine is given to prevent hepatotoxicity. Therefore, in nomogram, I had said if at 4 hours after 4 hours of ingestion of paracetamol, the concentration is less than 150 microgram, then hepatotoxicity is unlikely. Then N-acetylcysteine is not indicated. And when at 4 hour interval, it is more than 150, concentration of paracetamol is more than 150 microgram per ml, then it will be given again it will be the same. If 8 hours, it will be more than 75 microgram per ml. At 12 hours, when it is more than 37.5, then N-acetylcysteine will be given. IV N-acetylcysteine will be given. At 16 hours, it is 18.75, more than 18.75, and at 20 hours, concentration when after 20 hours injection of paracetamol, its concentration is more than 9.375. It is just half. 4 hours is the half life of paracetamol. So 150, 75, 37.5, 18.75, 9.375. If the concentration is more than this after 20 hours, if concentration is more than this after 16 hours, then N-acetylcysteine will be given IV. And what is the dose of N-acetylcysteine, IV N-acetylcysteine? IV N-acetylcysteine. Oral dose should be made as A in antidote section and B IV N-acetylcysteine. Number 1 is loading dose. Loading dose is 150 milligram per kg body weight in 200 ml NS infused over 1 hour. You can easily calculate how much to give per minute, because 1 ml is 15 drops, and accordingly you can calculate 150 milligram per kg in 200 ml NS infused over 1 hour. This is the loading dose of N-acetylcysteine. And dose 2 is 50 milligram per kg body weight in 500 ml NS infused over 4 hours. 50 milligram per kg body weight in 500 ml NS infused over 4 hours. This is the dose 2. And dose 3, loading dose is the dose 1. Dose 3 will be 100 milligram N-acetylcysteine per kg body weight in 1000 ml NS. 1000 ml NS infused over 16 hours. 1 hour, 4 hours, 16 hours. Duration will be 4 times, and dose is 150, 50, 100. Okay? So this is all about paracetamol toxicity. First you have to assess the concentration, and if it is in a hepatotoxicity range using the updated Matthew nomogram, you will be able to judge whether the N-acetylcysteine will be given or not. For oral administration, you will have to give 140 milligram per kg body weight first dose, loading dose, and 70 milligram per kg body weight every 4 hourly for 17 doses. For case of oral administration, you can go either way, oral administration. And for IV administration, you will have to look at the concentration. Again the same thing with IV administration, loading dose 150 milligram per kg in 200 ml NS infused over 1 hour, and dose 2 will be 150 milligram per kg in 500 ml NS infused over 4 hours, and dose 3 will be 100 milligram per kg in 1000 ml NS infused over 16 hours. So this finishes the paracetamol toxicity or overdose.
Sir, IV N-acetylcysteine is indicated if the concentration is more than according to updated Matthew mammogram.
Actually, N-acetylcysteine is indicated when the concentration is that much, and you can give either oral or IV. When the, as I already told you, according to the mammogram, when at 4 hours after ingestion the concentration is less than 150, then hepatotoxicity is unlikely, and therefore N-acetylcysteine is not indicated. And when the concentration is more than at 4 hours, it is more than 150. At 8 hours, it is more than 75. For 12 hours, it is more than 37.5, and so on and so forth. Then hepatotoxicity is likely, and N-acetylcysteine is the antidote. And you can give either way, either oral or IV. That has not the connection with the nomogram will be used both for oral or IV, and it is up to your choice or patient preference or the severity of patient. You can give IV or oral, but indication is the same, concentration level is same. And now we are coming to the management of aluminium phosphide poisoning. That is also called cell-phos poisoning. Number one thing in the management of cell-phos poisoning, as I have already told you in the general principles of acute poisoning, that in first 1 to 2 hours we have to give, we have to go for gastric lavage. So gastric lavage, number first thing to be done in management. We are talking about the management, not the features or the symptoms that you should read by yourself, because the purpose of class is to how to manage it. And gastric lavage, in case of first 1 to 2 hours of ingestion. This is helpful in first 1 to 2 hours of after ingestion. Number 2 is activated charcoal. What is the purpose of giving activated charcoal? Activated charcoal absorbs the phosphine gas, because this aluminum phosphate in contact with moisture or in contact with water releases phosphine, and phosphine is the ultimate toxic ingredient in case of cell-phos poisoning that hampers the oxidative phosphorylation in the mitochondrial crystal. So we have to give activated charcoal and vegetable ghee like coconut oil. Vegetable ghee prevents production of phosphine gas in stomach. This activated charcoal absorbs the phosphine, and vegetable ghee, phosphine that is already released, that is adsorbed, that is surface contact, that is adsorbed by activated charcoal, and vegetable ghee prevents the production of phosphine gas in the stomach. Vegetable ghee prevents the production of phosphine gas in stomach. So this is the importance value of giving vegetable ghee, activated charcoal and vegetable ghee. And number 3, adequate urine output. Adequate urine output and adequate ventilation. Adequate urine output and adequate ventilation leads to adequate excretion of phosphine from the body. That is equally important, because once phosphine has been in the body, it has to be excreted, and adequate urine output and adequate ventilation ensures adequate excretion of phosphine from the body. So this is also important. Now the next part of the management, most important point in case of cell wall poisoning is supportive treatment. Means patients other systems should be taken care of. If there is already another comorbidity, like patient is hypertensive, patient is diabetic, patient is already having some electrolyte imbalance, patient is having some hypoglycemia, patient is having hypovolemia. If there is any other thing, then supportive treatment is very essential. Number 5 is sufficient saline or normal saline is given for treatment of hypotension, because hypotension is very common in cell phos poisoning. Hypotension and also metabolic acidosis is very common in cell phos poisoning. So sodium bicarbonate is also given. So for metabolic acidosis, saline and sodium bicarbonate for hypotension and metabolic acidosis, because hypotension and metabolic acidosis should be taken care of in case of cell phos poisoning. Most of the time patient comes with hypotension and patient is also having metabolic acidosis. So you must, whenever you get a case of cell phos poisoning, you should get the ABG done and rule out whether the patient is having metabolic acidosis. And the moment you find metabolic acidosis, you will have to give the sodium bicarbonate. And number 6 point is magnesium sulfate. Role of magnesium sulfate in cell phos poisoning is controversial. It is not well established, but still it is, most of the clinicians use it. Magnesium sulfate, and we give magnesium sulfate in dose of 2 gram over 20 minutes in NS, over 20 minutes. This is the initial dose, 2 gram over 20 minutes in NS. You have to give in NS. You can give in 100 ml NS, 2 gram mixed with 100 ml NS over 20 minutes. Means 2 gram and 20 minutes is important. After that you can give 1 gram 6 hourly or 8 hourly. But it is controversial, but most of the time it is used in cell phos poisoning. So this is all about management of cell phos poisoning. Now we are coming to the management of cell OP poisoning, that is organophosphate poisoning. Management of organophosphate poisoning. So first of all, the most important part of the management is that protection of self, protection of your own staff and protection of your own self, because this is one toxin which causes toxicity through surface contact itself. Even if it is absorbed through your skin, it can cause toxicity. So first of all, protective clothing. Protective clothing for all staffs, including yourself. Protective clothing for all staffs, including yourself. And even if the patient has secretions all over his body, that clothing has to be changed for the patient himself, because he or she might be absorbing the toxicity through his own secretions. Those secretions which are already out through their secretions, but they are still getting exposed through their clothing, soiled clothing. So protective clothing for all staffs, and also the clothing should be changed for of the patient. It is if it is soiled by the secretions. Number 2 is supportive treatment. Supportive treatment, you have to take the vitals of the patient and take care of electrolyte, blood sugar, blood pressure. This is the supportive treatment. And number 3 is clear the airway. Clear the airway, because organophosphate poisoning causes copious bronchial secretion and bronchospasm. That copious bronchial secretions leads to choking of the airway and respiratory failure of the patient. Therefore, it is necessary to clear the airway through oropharyngeal suction and give oxygen therapy. Give oxygen, O2, and if possible, intermittent positive pressure ventilation. If the patient is not able to maintain the oxygen saturation by just giving the oxygen saturation through oxygen mask, then you will have to go for non-invasive intermittent positive pressure ventilation like BiPAP machine or CPAP machine. Or if that is not available, you can simply send the patient to ICU for ventilation itself. Number 4 is obtain the blood sample. Obtain the blood sample. Blood sample for what? Choline esterase estimation. Because cholinesterase receptors are get aged. That is called aging of the cholinesterase receptors. So cholinesterase estimation. This is the enzyme that whose estimation is essential in case of organophosphorus poisoning, and this is done in EDTA vial. EDTA vial in ice. EDTA vial in ice, because if it is not taken in ice, EDTA vial in ice, then this cholinesterase enzyme will be denatured. So obtain the blood sample for cholinesterase estimation. And even although we are not able to do it in this our setup, but ideally we should have the important. We should have the, because why it is important? It is specifically important in case of organophosphate poisoning, because there is a drug called pralidoxime, that is cholinesterase enzyme reactivator, and if the cholinesterase enzyme is already very low, then giving the pralidoxime has no meaning, because that will not work. So whether the pralidoxime will be effective or not, we should have the concentration of cholinesterase enzyme, because cholinesterase enzyme is deactivated in case of OP poisoning, and if its concentration, and pralidoxime is cholinesterase reactivator. It reactivates the cholinesterase enzyme. But if the cholinesterase enzyme itself is deficient in the patient from the beginning, there are patients in which cholinesterase enzyme is deficient. So in those patients, giving pralidoxime will not work, and that's why we will not give the pralidoxime. This is the real importance. After doing these basic things, we have to move for another thing about in OP poisoning. We need to give IV diazepam. IV diazepam. That is slow IV diazepam 5 mg for prevention of convulsion, because many times patient develop convulsion, or prevention of agitation if the patient is very much restless. We give IV diazepam slowly 5 mg for prevention of convulsion, or not prevention of convulsion if the patient has already developed convulsion, or the patient is very much restless, agitation. For convulsion or agitation, we give IV diazepam. And the real antidote of the organophosphate poisoning is atropine. Real antidote for OP poisoning is atropine. And how we give atropine? We give it through which route? IV route. In case of adult, the dose will be 2 mg. That is the loading dose. And in case of children, the loading dose is 0.02 mg per kg body weight. In case of children, 0.02 mg per kg weight body weight. Although we should not know this much about, but we should know about 2 mg loading dose, means 2 ampoule a stat. 2 ampoule a stat in case of OP poisoning, and after that we have to give atropine at the interval of every 5 minutes. Interval should be 5 minutes. And what we have to give at every 5 minute interval, we have to double the dose of the atropine. Means after 5 minutes we will be giving 4 mg, means 4 ampoule. After 10 minutes we will be giving 8 ampoule. After 15 minutes we will be giving 16 ampoule. And until when? Because of the copious secretions, in case of there is copious bronchial secretions and also bronchospasm. In chest there is crepitation in case of OP poisoning. So when the chest becomes clear, how long we will be giving atropine? When the chest becomes clear, systolic blood pressure becomes more than 80 millimeter of mercury, and pulse becomes more than 80. So these are the signs of adequate atropinization of the patient in case of organophosphate poisoning. In case of OP poisoning, you will have to give atropine 2 mg loading dose, and you have to repeat it at every 5 minutes, and the dose will be double the previous. So and you don't have to be hesitate in giving too much of atropine, because many of the patients require more than 100 milligrams of atropine to get their chest clear, systolic blood pressure more than 80 and pulse more than 80, and 100 milligram is 100 ml of the atropine. Many of the patients require 100, more than 100 ampoule of the atropine for their chest to become clear and systolic blood pressure to come more than 80 and pulse more than 80. Then you will, when you have achieved this level, then you will stop giving atropine, and your patient will be supposed to be treated. And another drug, important drug, is pralidoxime. Pralidoxime. This pralidoxime is given in case of organophosphate poisoning, and atropine is also given in case of carbamate poisoning. But in case of carbamate poisoning, this pralidoxime is not indicated. When it is indicated in moderate or severe organophosphorus poisoning. When there is pulmonary edema, patient develops pulmonary edema, and patient develops respiratory failure. In those moderate or severe cases, usually pralidoxime is given. Although somewhere it is written whenever atropine is indicated, pralidoxime also should be added. But specifically, it should be given when the case is more moderate or severe. Means patient has developed pulmonary edema in chest X-ray, you are seeing the pulmonary congestion, and the patient had developed respiratory failure like CO2 retention, and patient is too much breathless. In that case, you will have to add pralidoxime, and the loading dose of pralidoxime is 30 milligram per kg body weight. Infused, it is infused directly. 30 milligram per kg body weight infused over 30 minutes. This is the loading dose, 30 milligram per kg body weight infused over 30 minutes, and thereafter you will have to give it 8 milligram per kg per hour. 8 milligram per kg per hour, and usually after 30 minutes, there is apparent improvement in the patient condition. And again you will have to you will give it until the patient's chest becomes clear, systolic blood pressure gets more than 80, pulse rate becomes more than 80. So this is the dose, 30 milligram per kg infused over 30 minutes, and it is given that directly, not in minutes, and 8 milligram per kg per hour. And usually the improvement is apparent after 30 minutes. And maximum dose of this pralidoxime can be your 2 to 4 gram. 2 to 4 gram maximum. So accordingly you will have to give it. So this is all about the important poisoning and overdoses that I talked about. I talked about paracetamol overdose, aluminium phosphide, and organophosphate poisoning, and I think it was of some value to you people, and I believe from next time you will be able to handle in emergency the cases of these poisoning in a much better way. Yes.